Welcome to Evening Rounds, a podcast that takes you behind the scenes in medicine. Tonight, we're joined by Dr. Scott Lee, who is at the forefront of diabetes research and care, offering patients a new outlook on the future. If you like what you hear, please subscribe. Well, Scott, thank you for being a guest tonight on our Evening Rounds podcast.
Welcome.
Yeah, it's great to be invited. I feel honored to be a part of this podcast. So,
whenever I hear you talk in a meeting, I think every single person in the room, their cortisol level lowers a whole bunch because you have what I call the NPR voice, where it's very soothing, very calm, and just your cadence is just so fantastic. And it makes sense that you're kind of the Zen master. It sounds like that's a big part of your life. But I also found out that you are from the island of Oahu, which has to be one of the most Zen places as well on the planet. And to grow up there and to have that childhood must have been very unique. And even though I want to ask you if you've ever surfed, Pipe or Waimea Bay on a double overhead day,
Wow, you just dropped that.
I won't. I'll ask you, what was it like growing up there, and how does that influence who you are and how you address patient care?
yeah, the culture of Hawaii is much more kind of laid back.
And family-oriented.
Family oriented, a lot of outdoors.
A lot of Sabbath time, without calling it that. It's a lot of Sabbath time.
Yes, and almost like a Sabbath mindset too as well. So it's a very, it's a culture where people are very polite to each other. No one honks in Hawaii. Like, if you honk your horn in Hawaii, it's like considered one of the rudest things to ever do. So when
we need that here in California. Let me tell you.
To California, I'm like, oh boy, like people honk.
You get on the 10 and feel like you're gonna.
And actually, when I was in industry, I traveled to India. Well, in India, they just like every drive, they're just honking because they use it as a way to navigate so people don't hit each other. But in Hawaii, no one honks. And the other thing is, in Hawaii, people truly have the right of way when they're crossing the street. So if someone's just even inching towards it, the car's not speeding up to kind of, get in front of the person. They like wait, and then the person walks across the sidewalk. Now, I didn't surf, but I did what was called boogie boarding. Mm-hmm. Boogie boarding is just sort of this styrofoam board. Sponge board, right? That you go on the wave and then you ride the wave.
With fins
so I
or
love
without?
that. Without fins, actually, yeah. Love going to the beach. Grew up on Oahu, which is the main island, but then also would go to the other outer islands as well. What's interesting is when you visit Hawaii, you're like, oh, it's so small. But if you're actually born in Hawaii, you don't realize it feels big, actually. It's like, oh, I'm going to the other side of the island. So I lived on the main part of the island. I'm going to the other side of the island. It's like, 15 minutes or 20-minute car ride, which is not even long California term, right? So it feels really big, which is interesting, even on such a small island. So
That's cool.
yeah.
I love that.
You would characterize yourself not just as an endocrinologist, but as a diabetologist. Mm-hmm. Can you talk a little bit about what that means and what you do in your professional work?
Yeah, that's a great question. Interestingly, when I went into the field of endocrinology and I was doing my fellowship, I thought, I don't want to focus on diabetes. I just only want to focus on thyroid and other unusual hormonal conditions.
Why not diabetes?
Because at that time, 28 years ago, there really was only one or two pills that was out there. There was some insulin. It wasn't the best. And it was sort of chronic disease management. People didn't want to get their blood sugars under control because if they did, it would mean that they would gain weight because a lot of the medications were associated with weight gain and low blood sugars. And then when I was looking for a job, I wanted to be affiliated with an academic institution. Came upon Loma Linda because my family's here in Southern California. And one of the contingencies was taking over the diabetes treatment center. So I said, okay, I'll take it over. Well, after I took it over, I'm like, oh, I think I really, really enjoy diabetes. And then I began to see how with chronic disease management, if you really sort of pay attention and follow patients over time, you can make a big difference. And then within the area of endocrinology, it turns out that all of the research, the funding, the explosion of medications and therapeutics were actually within the field of diabetes, both in type 2 and type 1 diabetes. And so with my interest in research as well, it just was sort of a natural fit.
When I was a kid, I remember classmates and other school children, when they had diabetes, it was really a life-limiting disease. They were talking about, well, maybe she won't be able to have kids, or should she even get married because is that, and have a family because as a type 1 diabetic, how long will she even be alive? I mean, these were the questions that I remember as a kid growing up. Like diabetes was like disease without, a long-term sort of future. Can you give us a little bit of the incidence or the number of people living with diabetes in our nation, and is it going up or is it going down?
It's definitely, in the millions with diabetes, and the incidence is rising, both in type 1 and type 2. So it has...
What's type 1 and type 2?
Yeah. So type 1, typically when you think about type 1, it's when a patient develops diabetes as a child, and they require insulin. So pills don't really work, and their pancreas sort of shuts down. So they need to get insulin if they're on injections at least 4 times a day, or wear the insulin pump in order to live. And before, when diabetes was first diagnosed, basically people would die of cachexia. They would just starve to death because they would lose all the glucose. Their muscles would break down, their fat would break down, and then they would pass away. But then with the advent of insulin, patients were living, but the problem then was they were developing complications because the blood sugars were too high. So type 1, they require insulin, versus type 2 diabetes, patients are resistant to insulin. And so before we had some of these newer drugs, in type 2 diabetes, you would use insulin, but because they were resistant to insulin, you had to keep going up and up and up on the insulin. I always remember patients would be complaining, why do you keep increasing the medication, and all of this sort of thing. Now, I think the greatest innovation are medications where it improves the blood sugar, but also reduces weight. And that has been incredibly transformative. And patients' narratives now are different. Because before they'd be like, no, I don't want to increase my medication. Now they're like, oh no, keep going higher and higher. I'm like, no, let's focus on lifestyle. You're getting better.
Because when you go higher on these new medications, the weight actually goes down.
Yeah.
Because you're talking about like a GLP-1
right.
drug.
GLP-1,
Okay.
exactly, right.
And that is making an impact
That is making
in attitude.
Yeah, big impact on attitude and big impact on their overall life because their blood sugars are improving and their weight is going down. So instead of coming to each clinic discouraged as they did 25 years ago, they're actually coming and going, oh, my blood sugar improved. Oh, I'm losing all this weight. This is great. And I will say this one thing about lifestyle, which I have to get in because it's so foundational to diabetes management. And that is that when a patient actually is even on low doses with these new medications, but incorporates a healthy lifestyle. And so what I mean by that is exercising to get the heart rate up. And that can even just be as simple as walking. That improves insulin sensitivity. And then diet. Healthy diet, low in saturated fats, high in unsaturated fats. Unsaturated fats are things like nuts, avocados, the Mediterranean diet. When you combine those two things together, the outcomes are profound, much better than even the clinical trial data. I mean, significant. And the clinical trial data, they're very focused on getting the A1C down and the weight down. So they have these titration algorithms, and it's this sort of ivory tower setting.
That's a fascinating comment for our audience, because generally when we do clinical trials, the data in a clinical trial will be more robust than in the clinical setting because it's such a controlled environment. Your patient selection is very narrow. So to hear you say that these drugs are exceeding the performance of clinical trials is really 180 degree turn than what we generally see.
Right. Yeah. It's really, to me, synergistic when they do it. And on the type 1 side, what's very interesting to me is the vegetarians actually have some of the best outcomes. They said as soon as I started going to kind of a plant-based diet, it was easier to control. Now, we know from the scientific data that when you incorporate more plant-based diet, that the fiber actually has a lower glycemic index. So just combining the same amount of carbohydrate with fiber versus that same amount of carbohydrate without fiber, that the postprandial glucose is significantly lower when combined with fiber. And also the same is true of cholesterol as well, adding fiber.
I'll have you comment on the glycemic index. When I've chatted with my patients through the years, I say it's better to have an orange than the orange juice. It's better to have a grape than the grape juice, right? Yes. Yeah. And part of that is because of the soluble fiber delays the glucose absorption, which then prevents that insulin spike, et cetera. But when we talk about glycemic index, for people listening, what should they be looking for when we think about, because you can Google glycemic index in the food, and what does that actually mean?
Well, the term is used so broadly, and the reality is different patients react to different foods. So glycemic index to me is very individualized. Certain people react differently to certain foods. I will say, something like Panda Express probably doesn't have the best glycemic index. Blood sugars go very high. What I have found is foods that are high, and this is in clinical studies as well, but just in my own practice, foods that are higher in saturated fats. So that's like fried foods and that sort of thing. Those foods, not only does the blood sugar go up, but it stays up. So a lot of people are like, why are my blood sugars high in the morning? I ate dinner, earlier. And then I go back to what their diet was, and those that were very high in saturated fat actually didn't do well. But I have to make this caveat on diet and fat. Fat, the right type of fat, is actually good for you. So we know that omega-3 fatty acid, we know that fat that is found in nuts, so unsaturated fat, actually helps the brain. And I'm big into brain health and diabetes because there's higher risk of dementia. Now that patients are living long, there's higher risk of dementia. And we know with brain health that actually exercise and diet, and diet that has a higher degree of unsaturated fats, can actually be significantly regenerative.
What do you mean by regenerative? Does that mean I'm gonna go back in years and look younger? Does that mean I'm gonna not have dementia? What does that mean?
So when you think about the brain, everyone just sees a picture of the brain, but the brain is actually made up of fat. And so in order for the brain to sort of restore itself, it has to have the nutrients that will help the brain to heal. And so those nutrients are primarily unsaturated fat. The reason why exercise actually helps the brain to heal is because it's believed physiologically, there's higher degrees of blood flow that are going up to the brain that are helping the brain to actually heal. And then the other big factor is sleep. The body is not static. It's actually very dynamic. It's continually healing itself or not healing itself, depending on what we do. And we know that sleep actually has 4 phases of non-REM and then REM. So just to explain it, the first 4 phases are as you're slowly getting into deep sleep. The last phase of sleep is the deepest part of sleep. And then you have the REM phase. We know that it's the last phase of sleep, if you sleep long enough, and then the REM phase, that it's actually shown to be restorative to the brain. So it's been very motivating for a lot of patients when I talk about brain health, because it actually changes their diet, because they're like, oh, this is actually going to help my brain. They're not even sometimes concerned about their heart. They're more concerned, I don't want to, become demented when I get older. And a lot of people with type 2 diabetes have sleep apnea, which is where they snore and they don't get enough oxygen and they need to be on CPAP. And so sleep actually also plays a critical role in getting enough sleep, which, for...
Guilty.
Yeah, exactly. For professionals and busy people.
Yeah, I don't even want to know.
Yeah.
I may get to like stage 2.
Yeah.
So, I mean, there's wearables that show you how well you sleep. What's your take on that?
Yeah.
I think it's very interesting, and I think that some of these wearables actually have been validated in the lab to show that they're fairly accurate. The point of care, for any wearable when it first came out wasn't very good. But even if you think about the point of care for glucose sensors, I mean, it was plus or minus 20% when they first came out 20 years ago. Now it's close to a finger stick glucose for point of care. And point of care meaning when the patient is wearing the device itself versus in a lab or when you see the doctor or that sort of thing.
What do you mean? What is that?
It's an insulin pump is actually... It's kind of like a small handheld pager that now you can actually wear on your body, or you can have it attached to tubing, and it delivers insulin automatically. So patients don't have to inject themselves with insulin. So, when you think about injections, a patient with type 1 diabetes would have to inject 4, 5, 6 times a day, versus with a pump that has a reservoir of insulin, they're just injecting once every 3 days or every 4 days when they wear it. So the sensor, which checks the blood sugar now about every 2 to 5 minutes.
Incredible.
So, when you think about the difference between blood sugars 4 times a day versus 288 times within a 24-hour period, it's completely different picture of what is going on with a patient.
That must be like unbelievable for compliance, especially when you think about children.
Yes.
Like I know you're a friend from high school, but like I had a teammate who had to have to run to the sideline in between plays to like check and be injecting. And so that's you must see such better compliance.
Well, I always like to say it's one thing to treat a low, you go low and then you treat it. It's another thing to prevent a low, because when you go low and you're treating it, you're panicked. You overtreat, the blood sugar goes up. But if you actually prevent a low from happening, people tend not to overtreat, and you don't get this sort of rebound high.
I mean, I like to think about the amplitudinal variation, right? You'd like to narrow that wave, right? You want that sea of glass when you're water skiing versus, this choppy waters. Right. Let me change gears for just a moment. So when Dr. Lee takes off his white coat and goes home, what do you do from a whole person care perspective, diet, brain health, sleep? What are things that you've done to help in those categories that maybe some of our listeners can take a listen to?
So I actually in the morning do treadmill Monday through Friday.
Are you running or walking?
I'm walking.
Okay.
And thank you for asking that question, because it's something that I tell my patients, because they're all, when I talk about exercise, like, I have to go to the gym. I'm like, actually, you don't. Just moving, not getting off the couch. And moving around actually significantly improves insulin sensitivity and your response to medications. But that actually is not as motivating for my patients as when I tell them, if you actually exercise, it will significantly reduce your stress in your life. And there's clinical trials that show the two biggest impacts on lowering stress is reducing caffeine and exercise, and reducing anxiety.
Really convicting me now.
Anxiety
I'm going to
level.
leave this conversation.
So
Did you say reducing caffeine?
Yeah, reducing caffeine and exercise are actually the two single biggest factors for reducing anxiety in someone's life. But
Which is funny because when you're tired, you want to do the antithesis of those two things.
yeah,
Not exercise and have
exactly.
caffeine.
And have a whole bunch of caffeine.
Right,
Yeah.
exactly.
I'm speaking for myself.
Amazing.
But
Wow.
so when people actually, and I get this so many comments when people actually see me on the treadmill. So if I'm traveling and someone's there and they're in the gym with me and they're watching me as the treadmill, they actually start laughing. And the reason why they start laughing is because when I'm on the treadmill, I don't actually even break a sweat. I'm just walking really slowly. I'm
So
listening.
you're at like a 2 or a 3.
Yeah.
Really low.
Very low. I'm usually listening to a podcast and something like Evening Rounds and just exercising in the morning. But that small amount of exercise in the morning really has made a big difference. And now I've actually been doing martial arts. Now, I had wanted to do martial arts and I tried jujitsu about 10 years ago.
Very intense.
And found that my bones didn't really, I just wasn't a good fit.
Because that's like grappling on the ground with another human being.
It wasn't a good fit. It just wasn't for me. Anyway, then with my sort of crazy schedule, I'm like, how am I going to find a martial arts instructor that I can go to? And I can't do karate with fourth graders. I mean, just like, I don't know how to do this. Well, there's now online video martial arts that you can do. So I have
Is this like a video or like an actual instructor?
It's actual instructor
Oh, how cool.
who I do it through a Zoom meeting, and I put it onto my TV where I have like a little camera. And so my TV's pretty large. And so I have the instructor on one half of the side of my TV.
So 2025.
I know. And myself on the other side of it, and have been doing Kung Fu. There's Wing Chun, which Bruce Lee, I don't know, I'm maybe dating myself, who was a Hollywood actor who did Kung Fu, used to do as well. And so it's really been a lot of fun for myself. And that's another thing that I like to say about exercise. If you are doing exercise, it's critical that you do something that you enjoy and you like. Because for me, the idea of just going to the gym and lifting weights doesn't really excite me. I mean, I might do it for 3 months and then I just get tired of it. So I'm like, pick an exercise that's almost like a hobby that you get something out of it. So it's not just, I'm going to do this to improve my blood sugars. I'm going to do this because it's the healthy thing to do. No, I'm going to do this because I actually enjoy doing it.
100%.
So, so some of my patients, it may be dance. Some of my patients, it may just be evening walks with their dog or their spouse. And that's the more important thing because it's the sustainability, I think, that really makes a huge difference.
I love that. Yeah. So you have been one of our most active clinicians out of well over 1,000 physicians employed here at Loma Linda University Health in terms of doing clinical trial work. When you were a trainee, both during medical school and your post-medical school education, if you will, did you see yourself as what we would term a clinical trialist, where that would be a big part of your practice, or was that something that just came because of the field in which you were focused on?
Yeah, so that's another interesting turn because I did it in high school to get into medical school. I did it in medical school and residency to get into a good fellowship. So my goal was not to do research. I was doing research more as a means to an end. But then when I actually started the practice of medicine and seeing patients, I began to ask a lot of questions. And I began to say, well, why don't we do it this way? Wouldn't this be better? I could only do management to a certain extent, but it was limited in part by the innovations that were, soon to come out, over the next several years. And there's just been an explosion.
That's so fascinating.
Yeah.
I love that your curiosity really
Yeah.
has led you kind of down the path of research. And I know that's how I interface
Yeah.
with you a lot in my
Yeah.
day-to-day is really
Right.
talking about research and making sure that we're talking about the research Loma Linda is doing. And I feel like lately, after the pandemic and with some things that are going on with our government, there is kind of a general mistrust that we're seeing come out against research and kind of science in general. Talk about kind of what your role is here at Loma Linda and how we're trying to combat that.
Yeah, I think that's a really good point. And one of the things I think that I appreciate about Loma Linda and also just doing research at Loma Linda is, first of all, it's an incredibly supportive environment to do Loma Linda. So there's an infrastructure in place to ensure that faculty, when they're doing research, there's a transparency and a sort of a safeguard for safety and data. For me, data is critical, that it has integrity, that it's clean, because even the basics of analyzing data, you have to first make sure that the data is in a clean format so that when you do analyze it, the results are believable. And then you need to be transparent that when you do a clinical trial, sometimes the hypothesis may be met, sometimes it's not met, but just be open about the results are the results. And I will say to, the point that you bring up, that in the diabetes field, some of the most interesting studies were studies where the results were actually negative, where everyone expected it to be positive and it ended up being negative. And that was in a type 2 trial when they thought, well, if you normalize the blood sugars to a healthy range that's non-diabetes, that it would show actually improvement or a reduction in complications. Actually, it showed the opposite, that if you're overly aggressive, that actually you can have an increase in cardiovascular risk. But that was done with insulin and some of the older drugs. It might not be the same now, but still, I think data is data, results are results, and it's critical that you be very transparent. And I think that's one thing about Loma Linda and the environment. It's a safe environment to be transparent and to conduct ethical research.
Well, Scott, thank you so much for being on our Evening Rounds podcast.
Yeah, no, it's a lot of fun.
I'm thankful. And full of gratitude for what you do on campus, for your leadership and for your advocacy for patient care. So thank you very much.
Yeah, thank you.
A special thanks to the sponsor of Evening Rounds, La Loma, who has provided banking services to the Loma Linda community since 1955. Their support helps us continue bringing you episodes focused on health, story, and mission.